Today we are going to look at biliary pathology. But before we begin, please like, share, subscribe and put on the notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com, or you can WhatsApp me at +234 9019144175, or visit our online store at sonoeyes.business.site. Attend the quiz at the description and leave me a comment. You're welcome back. So we'll begin this discussion looking at spectrum of acute cholecystitis in ultrasound. Take a look at this case, this image, acute cholecystitis. Here you see a distended gallbladder with wall thickening. You observe fluid debris level and an obstructing stone in the gallbladder neck. You see the sagittal view and the transverse view of the same image. Other spectrum, you have a classical case of distended gallbladder, wall thickening, stone also in the neck of the gallbladder, as you see in the first case. Now in this image you have more advanced case with a thicker wall, larger lumen and multiple stones. This image shows a distended gallbladder with sludge and stone in the cystic duct. While this image shows slurred membrane in a gangrenous cholecystitis. This is a case of perforated gallbladder with disrupted wall. You can see the white arrows pointing at the area of perforation. And this image shows pericholecystic fluid collection. Now let's look at complications of acute cholecystitis. Each of the following conditions or complications with acute cholecystitis is associated with significantly increased morbidity and mortality, which are pericholecystic fluid collection, emphysematous cholecystitis, gangrenous cholecystitis, gallbladder perforation, and emphysema of the gallbladder. So let's start with pericholecystic fluid collection. Here you have an anechoic free fluid collection that may occur around the gallbladder fossa, which may indicate a small perforation of gallbladder. When present, consider as a surgical emergency. It may also occur in a non-gallbladder related conditions such as acute pancreatitis or perforated peptic ulcer. In emphysematous cholecystitis, this is associated with invasion of the ischemic areas in an acutely inflamed gallbladder by anaerobic gas producing bacteria, which produce gas in the gallbladder lumen and wall. Usually it occurs in elderly men, which will be about 3 to 7 times more common, and up to 50% of these would have diabetes. Gallstone is often absent. A perforation of the gallbladder, this is 5 times more likely than gallstone-induced cholecystitis. And gallstone-induced cholecystitis will be up to 20% of the cases, whereas 75% of the cases you have gangrenous cholecystitis, and high mortality will be found in 15% of them. What are the signs and symptoms? You have right upper quadrant pain and tenderness, fever with palpable distended gallbladder, maybe up to this, maybe up to right iliac fossa. And these are the common signs and symptoms. Sonographically, in addition to all the sonographic features of acute cholecystitis, the presence of air in the gallbladder and or bile duct, which is called pneumobilia, is demonstrated by an intense echogenic focus or multiple echogenic foci localized to the non-dependent portion of the gallbladder wall, like we will see. The intraluminal gas has an arc-like configuration and is associated with a ring-down reverberation artifact or comet tail artifact and or dirty acoustic shadow. Now here is the image of what we just described. Is gas in ephysematous cholecystitis. You can see focuses of intraluminal air that appear as bright echogenic layer in the non-dependent part with dirty acoustic shadow. Gallbladder is actually not visualized and may be mistaken as bowel gas, but knowledge of the gallbladder position in that line of the main lobar fissure or gallbladder fossa will help to identify this. In gangrenous cholecystitis, a gallbladder deprived of its normal blood supply or drainage will become gangrenous and will dilate with thickened edematous wall. Usually, this is a complication of stone impacted in the gallbladder neck or cystic duct. Gangrene may involve all or only part of the gallbladder wall. Perforation is a serious risk that is associated with gangrenous gallbladder. A Murphy sign is usually absent due to the denervation of the gallbladder. So sonographically, in addition to all the sonographic features of acute cholecystitis, gangrenous cholecystitis will show a rounded, tense gallbladder with an asymmetric, thickened gallbladder wall with multiple striations. Presence of floating intraluminal membrane due to necrotic slurring off of the gallbladder mucosa. Pericholecystic fluid collection will be found most commonly near the fundus. Let's look at gallbladder perforations. Most gallbladder perforations are subacute and result in pericholecystic abscess collection adjacent to the fundus. The region with the usually with the in the region with the sparest blood supply. Sonographic appearances are you'll find a complex pericholecystic fluid collection with septations. A non-visible gallbladder due to fluid collection around the gallbladder. Again, remember, if you understand the anatomy and location of the gallbladder, you'll be able to identify where you have a non-visible gallbladder. You have a thick hypoechoic gallbladder wall rather, and a cholelithiasis. Pericholecystic abscess or fluid collection exerts Mars effect, and it will deform the gallbladder. Emphysema of the gallbladder develops secondary to acute or chronic obstruction and bacterial infection. The content of the gallbladder becomes purulent. Pus can go through the gallbladder wall to the peritoneal cavity and may result in a localized or generalized peritonitis. Sonographic appearance are non-specific in this case, where you have low-level internal echoes or debris in the gallbladder lumen generating heterogeneous echoes. a wall thickness up to 10 times normal. You have gallstone in up to 80% of the cases, and pericholecystic fluid collection or abscess will be seen. In calculus cholecystitis or cholecystitis without stones, gallstones, 90 to 95% of acute cholecystitis is associated with gallstones or cholelithiasis. Only 5 to 10% of patients may have calculus cholecystitis. Morbidity and mortality rates are much higher in calculus cholecystitis, as the disease is frequently a complication of an unrelated critical illness. The predisposing conditions are burns, trauma, recent major surgery, debilitating disease, or immunocompromised patient. Most cases are a result of prolonged biliary stasis, ischemia, and biliary infection. 50% of patients with calculus cholecystitis are undiagnosed and progresses to gangrene and perforation. Sonographic findings of calculus cholecystitis are non-specific. However, you can have gallbladder wall thickening of greater than 3 mm, positive Murphy sign, pericholecystic fluid collection, intraluminal gas or membrane, low-level internal echo or debris in the gallbladder lumen. Color Doppler shows hyperemia or increased blood flow in an inflamed gallbladder. Whenever a hospitalized patient develops abdominal pain and has one or more of the above criteria, consider calculus cholecystitis. Here is an image of acute calculus cholecystitis. Here you see ultrasound at the gallbladder that is completely filled with sludge. You can see the sludge, and which is asterisk without stone. Then in this image you have Doppler sonography, which shows hypervascularization of the gallbladder wall, and that's the gallbladder wall with the arrow as a supporting sign of inflammation. Chronic cholecystitis is usually caused by long-standing presence of gallstone within the gallbladder. Signs and symptoms of chronic cholecystitis. Commonly, it is asymptomatic and may be symptomatic but non-acute cholecystolithiasis. May have recurrent biliary colic with right upper quadrant pain with history of intermittent similar pain. They have history of fatty food intolerance over a long period of time. Lab data may show no significant lab findings, but ultrasound appearance will show small or contracted and thick-walled gallbladder, sometimes difficult to visualize. 80% have cholelithiasis that fulfills the sonographic criteria. When gallbladder is packed with stone, the double arc shadow or west triad is seen. Here is an image showing chronic cholecystitis. This image is of a 49-year-old woman with chronic cholecystitis. This patient had fasted overnight, so the wall thickening does not represent physiologic contraction. Correlation of these findings with her clinical history or recurrent colic-like right upper quadrant pain due to transient gallbladder obstruction is essential for the diagnosis. You can see the west sign, the thickened wall, and the arrow showing the thickened wall. Non-visualized gallbladder on cholecystosonography. A non-visualized gallbladder should be documented with a scan of caudal or inferior end of the main lobar fissure, as this fissure is continuous with the gallbladder fossa. The causes of non-visualized gallbladder are a non-fasting patient. In a non-fasting patient, the gallbladder may be too small or contracted to see any fluid contents. 12 hours fasting is ideal for this case. However, at least 6 to 8 hours is adequate for hepatobiliary examination. Patient has patient has had a cholecystectomy, especially laparoscopy cholecystectomy. It can also be a diseased gallbladder with lumen obstruction. A small, shrunken, and contracted gallbladder in chronic cholecystitis is difficult to visualize. Obstruction that is proximal to the cystic duct could be one of those causes. A stone in the common hepatic duct may not permit bile to enter the cystic duct and gallbladder. Initially, gallbladder will be small, similar to that of a non-fasting patient. The patient will develop obstructive jaundice with dilatation of intrahepatic biliary tree. If the obstruction persists for a long time, the gallbladder will be filled with mucus and is called mucocele or hydropic gallbladder. A cystic duct obstruction will also prevent bile to enter into the gallbladder, and initially, gallbladder will be too small to see. Later, a mucocele or hydropic gallbladder will develop, but in this case, patient may not be jaundiced. Gas in the vicinity of the gallbladder in the duodenum or hepatic flexure of the colon can cause the non-visualization of the gallbladder. Also, hepatization of the gallbladder. If the gallbladder lumen is completely filled with thick bile or sludge, having a similar echogenicity of adjacent liver parenchyma, the gallbladder may be non-visualized, a phenomenon that is known as hepatization of the gallbladder. You could have blood, pus, or neoplasm within the gallbladder that may also have this appearance. Another reason may be anatomic variation. Agenesis or congenital absence of the gallbladder is rare, only in 0.03%. A totally intrahepatic gallbladder may be difficult to distinguish from hepatic cysts. In tall, thin patients, the gallbladder may extend into the right lower quadrant, or the fundus may be displaced to the left or to the midline. I want to thank you for joining our class today. If you enjoyed this lecture, please like, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com, or you can WhatsApp me at +234 9019 144 175, or visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. Until next time when I come your way again, keep learning ultrasound.